So thank you again for the invitation. So now we are going to talk about lung transplant patient. So it's a specific field, so I will try to explain the different issues we have with this patient in my hospital in Bordeaux. So first of all, we are interested in tidal volume and the way to ventilate the patient who are transplanted, because we start to do lung protective ventilation in the donor. We have data for that, just to improve the arterial blood gases and the compliance of the donor. So this has been done a few years ago, and we keep on doing this during the lung transplant. It's with open chest, we have low tidal volume, we increase the PEEP, and we recruit the lung, which has just been implanted very slowly. So this is what we do during the procedure, and the question is how we have to ventilate the transplanted patient after lung transplant. So it's difficult to target the tidal volume, because when we have a tall man who has pulmonary fibrosis, here is the CT scan and the X-ray, the predicted TLCs, these measured TLCs, total lung capacity, it's only 50% of the predicted one. So it's got a small chest wall. If you take a woman with only 1.58 meters, a COPD patient, the measured TLC will be higher because she's 140% of the predicted TLC. So in both cases, if you are only interested to the size of the patient, which is much different, finally the bigger chest wall comes to the woman with the smaller size. So this is the size of the chest wall will be the same after lung transplant. So we are interested in we've changed the lung, but we don't change the chest wall. So what we know is what we knew when we use pressure support ventilation. So we're supposed to target the level of pressure support to find the right level. But what is the right level if you don't know the total lung capacity and the disease of the patient, and you target the size? It will be different for the small lady in comparison to the tall guy, because one has a fibrosis and the other one had a COPD. So it's true that here, when you increase in PSV the pressure support, to increase the tidal volume. So the question was, is it possible to have this kind of regulation and adaptive auto-regulation of tidal volume that we know happens with NAVA in non-transplanted patients? So we have numerous studies showing that under NAVA, if you compare to pressure support ventilation, tidal volume is close to 6 meters per kilogram of predicted body weight. These patients are not transplanted. They are all different cases with RDS or COPD. But in all these studies, the comparison with pressure support have shown a significant difference with a lower tidal volume with NAVA. So the difference with transplant patient in the control of breathing, we have so lots of systems that have already been shown here yesterday. And the difference is that you have to cut the vagal nerve because you implanted a transplant. So the mechanical receptors from the lungs are not efficient anymore. But you still have the chemoreceptors and other receptors from the ribcage, the diaphragm, whatever. What is known is the HERING-BREUER reflex. There is lots of study in animals. In human, it's less important, and it's difficult to be sure of the key mechanism of this reflex. The study was done by this team. It was a long time ago. They were inflating the left lung with 1 liter, and see during the ventilation of the other lung what was going on. So here you have the tidal volume of the patient from the right lung. So when you inflate the other lungs, because you increase the distension, you stop the inflation, and this is the HERING-BREUER reflex. They try to block it with xylocaine, which is not an easy thing to do, I think. And they see a difference. The drop of tidal volume is because when you inflate on the other side, you decrease the volume of the other lung. So what is the effect of this pulmonary vagotomy on tidal volume during assist ventilation? When we want to assist the patient after lung transplant, if he has a pneumonia or a rejection, acute rejection or whatever, and if he comes back to the ICU a long time after lung transplant with a lung disease and you need to assist the patient, you have to choose the level of assist and the tidal volume. So here are the lungs from the day one in the operating room. And what we know of this lung with vagotomy, there are lots of studies at the end of the 80s and beginning of the 90s, because it was the beginning of the lung transplant program with heart and lung transplant at the beginning. That's why here it's heart and lung transplant, because we started mostly like this, even if the first pulmonary transplantation was done in Toronto earlier. But most of the transplant at the beginning was heart and lung transplant. And the control group, for example, in this study, it's a cardiac transplant group, and here are the control. And it's true that at rest, tidal volume are quite the same, but when you do exercises in the group of which has these transplant lungs, tidal volume can be very different from one patient to another. In some patients, it increases much more than in the control group. So there are lots of discussion from all these studies at the beginning of the 90s, and saying that probably the control of breathing has been changed because of the vagotomy, and tidal volume is probably increased too much in comparison to a control group. So we could expect that if we let the patient under proportional assist mode, that the tidal volume will be higher than a control group. So what we did is to evaluate this tidal volume in patients after lung transplantation. We were using NAVA in one group of transplant patients, and we compared to a control group without lung transplant. So here is the record of just every cycle during 1 hour, and here is the trends during the 24 hours of a transplant patient under NAVA. So what is interesting in this group of patients is that we know the total lung capacity, because it's based on that the surgeon are choosing the lung size according to the total lung capacity. So they have a specific, we're discussing that on the staff before the lung transplant to know approximately what size of donor we want, so predicted TLC for the donor, that will fit for the chest wall of the patient according to his disease, COPD, cystic fibrosis, or pulmonary fibrosis. So we always have this total lung capacity. What we do, we have a specific protocol for NAVA, which is always the same. We always use pressure support ventilation to assess the fact that the patient is able to breathe spontaneously for at least 1 hour. And then we test a spontaneous breathing trial, and if he fails, he goes to the ventilation with NAVA. And we use the data during the spontaneous breathing trial to titrate the NAVA level. I will show that after. So we had one group of 14 transplanted patients, and a control group of 22 patients. And this evaluation was done at day one of spontaneous breathing. So here the patient under pressure support, then here the spontaneous breathing trial, we use pressure support with 7 of assist and no PEEP. So the EDI is here, and we want to have 60% of the EDI during NAVA has to be 60% of the EDI during the spontaneous breathing. So here you can see that during the spontaneous breathing, EDI will increase here, and then we reduce, and we target to have a difference between here and here of at least 40%. It's important because it means that if the patient, once he will be on NAVA with this transplant lung, he's able to have more EDI if he wants. So he could have a higher EDI, a higher pressure assist, and a higher tidal volume. So what we found first is the tidal volume. On the control group, it was exactly the same level of what we have in the different studies about NAVA in non-transplanted patients. And in the transplanted group, we found a smaller tidal volume. So we could expect to have higher tidal volume, but that's not what we found. Tidal volume was a bit smaller than in the control group. If we look at both groups, here you have the non-transplant patient, 22 patients who are not transplanted, and here the transplanted patient. It's true that you have a difference of age because mostly we have cystic fibrosis patients in our patients, so they are younger. So in average, the age is different. And finally, a small difference, the difference in tidal volume here, and a small difference in the NAVA level. But for us, I think the NAVA level, because the protocol is just, we target a reduction of the drive, the difference comes from mostly the EDI when we started with NAVA. We tried to see if they had the same neuroventilatory efficiency to be able to say they start from the same, at the same level. It's a way maybe to be able to compare the two groups. EDI was a bit higher in the transplanted patient, but not significantly. And the arterial blood gases, we had a small difference in the pH, probably due to a higher PCO2. So we had higher PCO2, but the pH was controlled, and a smaller tidal volume. If you look at each patient, so that the 14 patients, the distribution was very different from one patient to another. And here it's the coefficient of variation of the tidal volume. So some patients had higher coefficient of variation, others had quite similar coefficient of variation as people without lung transplant. Here it's 2 weeks ago. It's a patient after a lung transplant and lung transplant. So just to see that he's breathing quietly and there's no increase, or because lots of studies about vagotomy in animals, you see lots of variability. So it was just in a way to show you that it's quite similar to what you will see with untransplanted patient. So the second aspect is the total lung capacity that was measured. So here you have all the patients, so pulmonary fibrosis, COPD, or cystic fibrosis. So here's the age of the patients. And we still have here this patient with fibrosis, the tall man, and the little lady with COPD, which had a higher total lung capacity in comparison to the man. So at the end of the surgery, we can check that the lung is not going outside of the chest wall, so it means that there's no mismatch of size once we are ventilating room air. We do this collapse it's in a way to be sure that the compliance is good just before we stop, we close the chest. So what we found, if you look at the tidal volume and the age of the patient, you won't find any correlation, because you have tall guy with small TLC and small ladies with high TLC. So if you take into account the total lung capacity of the patient, under NAVA, we found a correlation. So it could be interesting to have a mode that will fit the total lung capacity, even if you have a vagotomy, because if you don't know the patient and you have to choose the tidal volume, you won't be able to use the patient age. And this is where we can calculate the tidal volume according to the TLC. So what we found, it's true that this transplant patient, they don't have any vagal nerve, so it's supposed to be to have no HERING-BREUER reflex, but probably other mechanisms are involved, and we have mechanism receptors in the chest wall, in the diaphragm, and you still have the chemoreceptor with oxygen and CO2, and probably finally it's in our practice, because we use NAVA, we haven't seen anything different, and it was a way to show you this. And it's the first description of assisted ventilation, where the patient the assisted ventilation is correlated to the total lung capacity. Whether this mode will improve the patient outcome, we don't know. Thank you.
Thank you. Thank you, Hadrien, for this nice talk. Questions? Let me start. It has been shown in humans that, and contrary to animals, that HERING-BREUER reflex needs, in order to be activated, relatively high tidal volumes, in the range of 1 liter, or probably more than that. Any comment about that?
Yeah, it's true. When you look at all the papers, and even the one I've shown, it was 1 liter inflated in just one lung. So It's not in both lengths, just with a double luminant tube. So probably it's effective, but in higher tidal volume than the one we are using in mechanical ventilation, in ICU. And it's also true that so the tidal volume we use is smaller, and so it's also possible that we have some residual sedation, which inhibit a little bit this, which could explain that we don't see at day one. But finally, when you look at all the course of the patient during all this stay, we don't have like all this variability. But it's true also that probably if you cut the nerve of a patient just in front of you, you will see something just when you cut the nerve, and because we are days after that, other mechanisms are. All the studies in animals, they see something when you cut the nerve. We have seen yesterday with Christer these rabbits without vagal nerve. So probably there's other mechanism, and just only one thing will control tidal volume in humans. So if you cut the vagal nerve.
Did you analyze your results breath by breath? I mean, did you find any breath which was quite high in terms of tidal volume?
During 1 hour, yes. But during 24 hours, it's the trends of the CROI, so you have an average of 1 minute. But in average, it's almost never, it stays around between 5 and 6 meters per kilogram. Sometimes you have like 1 minute, which is more like 8 or 9. But I don't know if it's because the nurse is inside the room and we turn the patient and something happens. It's true that it's not during exercise or respiratory failure. We reduce the drive with the protocol, so he's breathing quietly. And maybe if a patient arrives with respiratory failure, but we don't do that, and we try to use NIV with NAVA, it's different. I don't know. Maybe in that condition, because the drive is very high, we have increased tidal volume.
Okay.
I don't know.
Other questions? Oh, okay. Can I mean, we have 1 or 2 minutes. So I think that these results suggest that during, in critical ill patient, chemical feedback is extremely important and not reflex feedback. What do you think?
The chemical feedback?
Yes.
It's true that we had some patients with hypercapnia, and we did not find any difference. In the control group, the CO2 was quite normal. And in the transplant patients, some of them, the one with small total lung capacity, they had higher CO2. But because they have smaller chest wall, maybe that's why we don't find any difference. Finally, the tidal volume is the same, but the chest wall is smaller.
Okay.
But the patient could have more than what he's doing. He still have, because these patients, they are more like 4 milliliters per kilogram. And we know that they can have more because we know that the EDI was reduced of about 40%. So it's possible for them to increase from 10 to 15, for example, of the EDI, then to have more pressure and more tidal volume. But they don't do it. But the pH was normal. It was higher CO2, but the pH was regular. Some of them had respiratory, renal failure due to immunosuppressive therapy sometimes. So it was, in these cases, maybe it's different if you have acidosis.
Okay. Thank you very much.